Hello, everyone, and welcome to the role of palliative care in cancer care. We're glad you could join us. My name is Elaine Gonzalez. I'm the community educator at the Breast Cancer Resource Center, or BCRC. I'm pleased to serve as your moderator today. The Breast Cancer Resource Center is a community-based nonprofit serving Central Texas impacted by breast cancer since 1995. Strengthened by our mission to empower those affected by breast cancer with personalized support and compassion, and in collaboration with our community partners, BCRC envisions a future where no one faces breast cancer alone. BCRC offers individualized patient-centered care from diagnosis through treatment and into survivorship. Through its two pillars of support, guidance, and education, BCRC certified patient navigators, whom all are breast cancer survivors themselves, empower those touched by breast cancer to become active and knowledgeable participants in their healthcare journey. This program is provided as a part of a cooperative agreement awarded by the Centers for Disease Control and Prevention to expand our programs for young women. The purpose is to increase the availability of support services for young breast cancer survivors, young women with metastatic breast cancer, and their caregivers and families. The CDC funding continues today. It's now my pleasure to introduce Dr. Kate Tindall. Dr. Tindall is the medical director for Austin Palliative Care. She is a dual board certified in internal medicine and hospice and palliative care. She completed her training, including her palliative medicine fellowship at UTSW. Before joining APC, she was the assistant medical director of the palliative care team for Parkland Hospital, as well as assistant professor at the UTSW Medical School in Dallas. She brings a passion for providing compassionate, patient-centered care to the seriously ill population and is thrilled to offer this care to the Austin community where she grew up. Dr. Tindall, we're happy to have you with us today. Please join us on screen to share your presentation.
Thank you so much for having me. I'll make sure I'm keeping track of time here. She already did my introduction, but I've worked in the field of palliative care for some time, and I've been fortunate to have the experience of working in a lot of different settings. So my initial work was on the inpatient side. I've done clinic-based palliative care, and now I have really been passionate about the work that we do now, which is bringing palliative care into people's homes and being able to provide what we call community-based palliative care. So I'm thrilled to be here today to talk a little bit about palliative care. I want to introduce the idea of palliative care in general, and then we'll talk a little bit more about how that works in the setting of sort of oncology. So the objectives for today, I want to hope that I will give you a good definition for what we call serious illness. Hopefully we can recognize at the end of this the domains that palliative care addresses and understand the team-based approach that we use in palliative care. And then finally, I've learned from giving these presentations that once I get to the end and it seems like something that might help people that that are around you or that you're trying to connect, it's not very helpful unless you know how to get to those resources. So we'll talk a little bit about tools that you can use to identify those types of resources. So what is palliative care? I find that nowadays, when I'm talking to new groups and I'm talking to patients and families, I see the whole spectrum from people never having heard the term palliative care to having heard the term palliative care, but not really having a clean picture of what it is, to having had personal experience with it. So I like to start with just sort of defining it. And I find that this is helpful too when you're trying to use the right terminology to introduce it to patients and families. So palliative medicine is specialized medical care for people facing serious illness. And we're going to come back to that. It is by definition provided by a specialty trained interdisciplinary team. And ideally that team is comprised of physicians, nurse practitioners, nurses, social workers, and chaplains. For physicians, it is now a recognized specialty where most people who are coming into the field now are going through a fellowship, meaning that they spend additional years in training before they can sit for the boards and become board certified in that field. There are certifications also for other disciplines. So for nurses, nurse practitioners, social workers, and chaplains can be certified in the field as well. So coming back to that definition, we use the term serious illness. And I wanted to define it because we take care of a wide variety of patients with a wide variety of diagnoses. And sometimes it can be a little bit difficult to really capture all those different classes of people in different settings of where they are. So serious illness is a health condition that carries a high risk of mortality and either negatively impacts a person's daily functioning or quality of life or excessively strains his or her caregivers. So for example, someone who might be dealing with a chronic illness like COPD, but they're in a stage where it's really not impacting their life excessively. You know, they might be seeing their pulmonologist a couple of times a year, adjusting their medications. They are on treatment for it, but they're pretty much going about day-to-day life as it is. Whereas as that illness gets more advanced, the impact becomes greater. They might have oxygen requirements that really affect their need to ambulate, to get around. They might lose the ability to go to work and do their job. And their caregivers might need additional support and help as well. So that's where we kind of cross over to the territory of where palliative care steps in. This diagram, I think there's a couple of different things that I find interesting about it that I wanted to share. So one is that you can kind of see on there that there's this place for where hospice comes in. And a lot of times people feel really confused about what the difference is between hospice and palliative care. And hospice is actually a form of palliative care. If you think of like the big Venn diagram, hospice is a piece of it. But a lot of times, sort of colloquially, we talk about palliative care as what people receive before they're on hospice services. And hospice services are very defined because it's a Medicare benefit or it's through your insurance. And it's defined as having to be required that patients have a prognosis of 6 months or less. Palliative care you can think of as sort of everything upstream from that. So, you know, the thing that I think we have recognized in serious illness is people don't wake up one day and suddenly need additional support and are in a place that they're ready for hospice. It really happens on a continuum. There's lots of times that people go up and down in terms of how much the disease is impacting their life. And the nice thing about palliative care is we can follow along in that trajectory. We don't assume all aspects of their care, which allow us to sort of come and go as we're needed. So if you look on that diagram, sort of the earlier phase where diagnosis happens, we're often not as involved, maybe not as important in kind of the overall care that they're receiving. But as complications happen, we might kind of get more involved for a period of time just until things stabilize. And then we might sort of take a step back and be waiting in the wings. But as the illness advances, the palliative care needs usually increase. And that's when a palliative care team really needs to be ready to start to sort of provide this wraparound care to patients and families. That's all I wanted to tell you about that. So when we think about palliative care in oncology, there's a couple of things I really want to point out. One is that palliative care is additive. And by that, I mean that people don't have to stop with any other medical care interventions that are benefiting them. So for example, if they're receiving chemotherapy, then they can continue with chemotherapy. Outside of oncology, or even sometimes within oncology, people might be getting dialysis. They can continue with that. Even things like home health are actually not duplicative with palliative care, even palliative care in the home. They're an additional layer of support. So we can come in, and what we aim to do when we come in is be coordinated with other things that are going on. So we look at the resources that people have. We're going to talk a little bit about the domains that we address. What we're kind of looking for is gaps in care and where we might be able to sort of intervene in a way that's helpful. Sometimes people have, you know, really intensive social work support through their oncologist, and our additional social worker might not be quite as necessary. Whereas we might be seeing somebody who's in a clinic outside of oncology that doesn't have that kind of support, and then we can step in and provide that as well. And then the last piece is ideally palliative care is really incorporated. So I would say as palliative care advances as a field, oncology is actually a place that we have traditionally really grown in. And I think oncologists have been really welcoming of that kind of support. We do aim to support the oncologist as well as the patient and family, and really all the medical teams that are there. But ideally, we're doing that in a really, in a way where we're having conversations, we're making sure that we all understand what's going on, we're all on the same page, and we're all making sure that the care is the right care. There's a couple of ways that people have accomplished this. You know, we work with some oncologists that really embrace the collaboration, and we try to make ourselves on our palliative care team really available to them so that we can have the conversations. Sometimes palliative care clinics will actually be embedded in oncology clinics, which means that their palliative care team will be housed in the same space. And so when you go to your oncologist appointment, you might then have a concurrent palliative care appointment with your specialist there. And the nice thing about that, beyond just the fact that it's helpful to not have a totally separate clinic and to make it a little bit easier, is that it allows for really good communication coordination between the two teams. You know, if they're in the same building, they're able to have conversations a little bit more easily. So I've seen that be very successful. So these are the domains that we address. And this is not to say that for every patient and every visit that we're talking about all of these things, but when we think about the ways that people are impacted, right, the whole goal of palliative care is to understand the patient experience and the ways that their illness impacts their life and address the things that are affecting the quality of their life to reduce the stress, reduce the burdens that they're experiencing. So we attend to the physical, the emotional, the spiritual, the financial. We talk about decisions, communications, and we talk about caregiver support. When I am in a new patient visit, my team's in a new patient visit, a lot of times when we're listening to people, what we're doing is really listening for these types of areas to think about how we might be able to step in and help. I'm going to talk a little bit more about the physical and emotional context and how we address that. From a spiritual perspective, we try to see where people are. There's some people that their faith really doesn't, they might not have a strong faith or one at all. And that's perfectly okay. There's other people that is a huge part of their experience with their illness and their life. And so we want to make sure that we're getting them the support that they need. A lot of times we'll have a chaplain on our team who can help do a lot of different things. You know, sometimes they're doing sort of a life review. Sometimes if people are talking about the ways that their faith is impacting their thoughts about future treatments or even after treatments, they're there to help have those conversations and support them. From a financial perspective, you know, I think as healthcare recently has started to more formally recognize that people's access to resources can have a dramatic impact on their health outcomes. And I'm glad that we're recognizing it. I won't say that there's always enough support to make that so that people have everything they need. We're far from that. But we, I think, have been able to address the idea that if people can't get to their chemotherapy appointments, then they're not going to be able to treat their disease in the same way. People can get to their dialysis appointments. Or I saw a patient the other day who was prescribed an oral chemotherapy and sent home, and the copay for it was $3,000. So they are in limbo trying to figure out what to do in that situation because that's not affordable. So, you know, we really want to think about the ways that we can reduce the financial stress. Then when we think about the caregiver, again, I think in healthcare, we have come to a place where we've recognized that caring for the caregiver is a way of caring for the person going through the illness. And also, there are huge impacts on caregivers long-term. We really don't have a society right now that makes it easy on people. You know, their jobs aren't always flexible enough to allow them to take enough time to be the caregiver of their loved ones. And even in the best case scenario where people can be there 24 hours a day providing all that support, it's still very stressful. And anytime we can make sure they have the resources they need, make sure they have the attention to what they're going through and the education and the support, it can make a huge impact on the entire family. So that's something that we make sure we attend to. when it comes to decisions and communication, that's a really big part of our training in palliative care is how to communicate. And really the focus is when you think about earlier states of illness, or you know, if I have a pneumonia that I need a course of antibiotics, there's not a lot of decision to make. I'm going to take some antibiotics, I'm going to get better. But when you get to a state where illness is more complicated, decisions become very complex, and they might become complex because the decision holds a lot of uncertainty. This day and age, we have had just truly amazing advances in oncology treatments and types of oncology treatments. But sometimes that puts people in a position where the oncologist doesn't have a really good amount of data to help guide them in what to expect. And we kind of have to make decisions within that state of uncertainty, which is more complicated. The other thing is, you know, sometimes people are really faced with decisions where they feel ambivalent. Not ambivalent because they don't care, but because they're facing maybe two decisions where neither one is what they would want. And we're having to sort of navigate two complex decisions that, you know, each hold sort of pros and cons, and we want to work through that in the best way. And then decisions are, you know, these are emotional decisions as well as sort of cognitive decisions. And so we really need to make sure that we are supporting people in the processing of having the right information, having the right support to have the right discussion. At the end of the day, our goal in palliative care is that everybody feels really empowered, that the decisions that they're making are the right ones for them. And that might look very different from family to family. We talk a lot about what people's values are. And what's different about the way the palliative care team approaches it is it's much, we try not to say, here's choice A and here's choice B, which one would you like? We try to approach it as, let's talk about who you are, what you value. Let's talk about how these decisions might impact what worries you have about these two different decisions. And then together, let's form a medical plan that feels like we're taking the experience and expertise of the oncology team and the palliative care team and the person as a unique individual, and we're putting it together to make sure we're making the best decisions for that person. So I wanted to talk a little bit about how we address the physical and emotional side of things. And I just want to sort of share, I thought this graph was interesting. So when we think of illnesses, a lot of times, you know, palliative care addresses illnesses outside of cancer. We take care of patients with dementia, chronic kidney disease, chronic liver disease, heart failure, COPD. And what we have found is that the symptom burden that people experience really extends beyond what you might think of initially as the disease process, as coming from the disease process directly itself. So, you know, for my heart failure patients, fatigue is a huge piece of what they deal with. And you think, oh, well, they're probably feeling short of breath because they're dealing with volume overload, and that can be part of it. But that's not the only symptom that they experience. Same thing with COPD. Patients certainly deal with breathlessness, and we do a lot of work around how to make sure we're treating that properly outside of just treating the disease itself, but treating the actual symptom of breathlessness. And they also additionally have a lot of concurrent anxiety that comes really as a sort of counterpart to that breathlessness. And so we find that we almost always are attending to those concurrently to make sure that they're well treated. So for an example, when I think about the way that we approach pain, you know, I've had people before say, well, you know, my primary care doctor, my oncologist, well, they can write the hydrocodone for me. That's not a big deal. But palliative care, the way we think about pain really goes beyond just taking a medication and prescribing it. And I just wanted to give sort of an example. We address most symptoms sort of in this way, but pain, I think, is one that is really a little bit easier to understand. So, for example, when someone's telling me about their pain and I'm hearing the history of it, I'm really looking for what's causing the pain, what's the etiology of the pain, can I understand what's happening as a process? Have I reviewed the scans? Do I know where things are affecting them? And the reason I do that is because that really informs the choice of how we can treat it. And there's also a lot of pain patterns that can exist. So for pancreatic cancer, for example, almost everybody who has significant pain directly from their cancer will describe it as sort of this gnawing pain that starts in sort of the mid-epigastrium and shoots to the back. And I've had a lot of patients that I've gotten that have described back pain for people who don't understand the process for why that's happening. And they'll be put on muscle relaxants for their back pain, when really that's not the way that we attend to it. So we think a lot about the etiology of the pain, and then we think about the different interventions that we can use beyond just medications, right? Sometimes people will have disease that has affected the bones, and we can use radiation very successfully. I had a patient who was on really high doses of fentanyl patches from his prostate cancer that had affected his bones. And after about a week of radiation, we actually were able to start titrating down on the pain medicines, and he actually came all the way off all pain medications. Sometimes what we can do is use nerve blocks as a way to reduce the total amount of sort of opioid class of medications that we need. And that's often really helpful to address it from sort of a multimodality standpoint. The other thing that's kind of different about what we do is we talk about the goals for pain management. We talk about sort of what are we aiming to achieve. So people will tell me, I have this pain, I can kind of live with it. It's bothersome, but I really need to be able to drive the car and pick up the kids. So we need to have a plan that accounts for that. Or they might say, this pain is so severe that I can't even get out of bed to get to my chemotherapy appointments or to my radiation appointments. And we really need to have sufficient pain control so they can get those interventions. And then we talk about sort of the risks and side effects, and we talk about what we're trying to avoid. At some point, we might have to really think about the trade-offs and make a decision on them. But a lot of times we're able to sort of have concrete goals and make sure that we're aiming for those goals, understanding what the patient needs from us. And then the other piece is there is an emotional and psychosocial response to being in pain. And that is reality. That's just what exists. So, we have pain sensors out in our body, but pain is a supratentorial process, and it's processed up here. So when people are in pain, sometimes the fear of what that pain symbolizes, whether it's, is the pain just going to keep getting worse? Does the pain symbolize progression of disease? Those things can really affect the sensation of pain. Same thing with, sometimes I'll see people and they'll have pain medication and they won't be using it at all. And with discussion, sometimes they'll tell me, I really feel like if I take this pain medicine that people are going to think that I'm, I have a problem with pain medications, or, that people around me will think that something's going on. And so we try to work through those pieces of it too, because at the end of the day, being in pain is something that takes a lot of energy. And being able to address it and treat it properly can really help people's quality of life. So that's hopefully kind of giving you a little bit of a picture of how a palliative care team works. We really work as a team, and we're trying to make sure that we attend to the patient, meet them where they are, empower them for what they need, and become really a part of the team with them to make progress in terms of reducing the stress of living with serious illness. I will say I wish that palliative care was defined across the board and uniform in what you will receive when you look for palliative care, but we're not there quite yet. There's also a huge discrepancy in access to palliative care depending on where you live. So this is a map from 2019, but you can see that some of the sort of northern states have much higher rates of access to palliative care. This is actually a graph of access to palliative care from a hospital perspective. That's really where palliative care started. And if you are in a hospital bed that has 300 or more patients, you have a much higher chance of having access to palliative care versus sort of smaller, more rural or community hospitals. You can see Texas is not doing that great. We're pretty behind the times in recognizing that this is something that can help patients and families, and making sure that we have enough resources for it. So when people are considering looking at a palliative care team and trying to understand sort of what that could offer families, these are some questions that I think are really helpful to address. And one I haven't put on here is understanding what the criteria are for the patients that they service. So palliative care is a resource that's pretty limited. I think for palliative care physicians, we graduate something like 300 physicians a year across the country. And there's something like 100,000 seriously ill patients per every physician that could possibly treat them. So it's kind of a limited resource. And because of that, sometimes people design programs really specifically to meet the needs of their community that they feel like are the greatest needs. So like a hospital might have, a sort of broader approach to who they treat in terms of palliative care versus a home-based team, which is obviously a little bit more limited in how many people they could get to, might have a narrower criteria. So it's really important to ask people what their eligibility criteria are for their specific service. Then I think it's really helpful to ask, is it a team-based approach? If you look on their website and they don't list any teammates, I would question it. A lot of times people will put the name palliative care on something that may be just a nurse or just a case manager, which is not to say that those aren't helpful pieces, but by definition, palliative care has a team that has to consist of, having someone to attend to the medical needs, having someone to attend to, a nurse, a social worker, a chaplain to attend to all those different domains. The other question is sort of how are patients seen and who sees a patient, who's doing the actual visits and how are those done? I think we have had some really interesting innovation in the field of palliative care. There's some companies who are trying to sort of combine inpatient home-based palliative care with some telehealth so that we can make sure we can get more frequent visits to people so that they get the care that they need. And that's really ever changing depending on regulatory policies and sort of insurance reimbursement. The other thing is sort of how frequently do they see them? Serious illness doesn't happen on a regular time frame. So while seeing your doctor to attend to your high blood pressure might be okay to see them every 6 months, it's usually not very helpful if that is a defined frequency. For our team, what we do is we see patients, and when we're in that visit, we'll define the next period of time with them about sort of what kind of frequency it is that we need to see them. If there's a lot going on, if we're working on a lot of things together, we need to see each other more often. And if things are really stable, maybe the patient's doing a bunch of other visits that are taking up a lot of their time and they kind of want us to take a step back, then we can do that too. And then I think the other really important thing is how do they attend to urgent needs? So you really want to be able to access your palliative care team really 24 hours a day. If you have a plan with them 1 week and the pain changes, in the middle of the night on a Saturday, you really need to be able to get to them to have that need adjusted. We have a physician on call 24/7. I wish we could send somebody to the patient 24 hours a day. We can't, but at least we can have somebody on the other end of the phone to give advice, prescribe medications, make adjustments, talk through what sort of our resources are in that moment and make sure that we're helping them as much as we can. And then the other two questions are kind of what role do they assume? Do they really take an active role in the patient's care, or are they kind of out on their own doing, maybe just advanced care planning or something like that? Again, that's really not what palliative care is. It's really wraparound care that can look different patient to patient, but they should be able to assume the aspects and the domains of palliative care that patient needs. And then lastly, do they prescribe medications? So it's important for them to be able to manage those pain medications. The opioid crisis pendulum that has existed in healthcare has really affected patients who have cancer-related pain and true needs for opioids. We have people who we have to call 5 different pharmacies to find the medication that they need. My nurse spends a lot of times doing prior authorizations to make sure that medications get covered. And it's really cumbersome, but we do it because it's important. But sometimes primary care offices or oncology offices, they might not have that experience to know how to do those. They might not have the time to do them. So ideally you have a palliative care team who's going to take that burden off of the other teams and really own that piece of it. So I just want to end with the idea that, a lot of times this service can be really additive and helpful to patients and families, but it's not something they always know to ask for. And so you can really be an advocate for them if you evaluate what kind of services exist in your community. And I really encourage people to proactively reach out, find out what kind of programs are around them and who might access them. And then form a line of communication. The absolute best care, especially in oncology care, the absolute best care is when people are working in a coordinated fashion and they're talking. They're making sure that everything is sort of communicated, and that way everything is more seamless. And that's really the whole point. We want to reduce the stress that people who are living with serious illness already have to go through and make things a little bit easier. And if we do that together, then that's really where we get the best outcomes and the most impact.
Thank you, Dr. Tindall. That was an excellent presentation. It's now my pleasure to introduce BCRC client Lindsay Woods. Lindsay is a UT grad that set down roots in Buda, Texas in 2014. She runs her own small business, Purple Magnolia Design, creating graphics and providing marketing services. In 2021, she was diagnosed with stage 2B triple negative breast cancer at the age of 32. After 1.5 years of treatment, the cancer progressed to stage 4. Despite living with breast cancer, Lindsay continues to grow her business, spend time with her 2 sons and husband, and live life. Lindsay, we're happy to have you with us today. I will turn it over to you.
Appreciate it. Can you hear me?
Yes.
Okay, great. So I did begin my cancer diagnosis in 2021, January. It came out of left field. We really didn't know anything about the cancer or treatment options, and definitely not much about palliative care. I had 2 sons and a husband, and we were just living life with, cancer not in our sights. I've never needed the palliative care for my first treatments as stage 2. During this time, I did see some references to it on an Instagram page for young adults, and it kind of gave a brief little like palliative care is not hospice care, ask about it if you need it. And I mentioned how it's not just for terminal patients. So kind of kept that in my back pocket. I didn't have that many side effects at home, so that, moved on to other things. Even as I was diagnosed at stage 4, I didn't have that many side effects at the beginning of treatment, of chemo. It's pretty mild side effects. However, this January kind of brought about a lot of intense pain. I wasn't able to, I didn't have an appetite, so I lost over 10 pounds in a few weeks. I had severe chemo-induced diarrhea and constipation, maybe TMI, but I'm sure we've all been there if we're been in that breast cancer treatment. And I also had insomnia because of night sweats 5 to 7 times a night in the extensive pain. My oncologist was managing all of this, but finally referred me to a palliative care doctor so that they could spend the appropriate amount of time managing those symptoms. My palliative care appointments were at least an hour long. I was getting what I needed from my oncologist. They were focusing on treatment plans and different trials and just more of the cancer-related aspects of cancer instead of really taking the time to figure out how much I needed and how often I needed, whereas the palliative care team was. Just last week or maybe 2 weeks ago, I was trying to get a refill for my pain meds because it's a roller coaster. And the palliative care team called into 3 different pharmacies for me to get this Dilaudid. Like Dr. Tindall said, it's really hard to get, and it's like you wait a week, it's still not there. You would if we didn't keep calling other pharmacies. And so we finally found it thanks to the palliative care team helping me and, achieving my calls or receiving my calls after hours. And I think even on a Friday night. So that was just a huge thing. My oncologist is great, but that's not exactly what he does. He's not going to, the nurse really focuses on that. So I've been so appreciative of the palliative care team, and that my doctor referred me to it, and that he didn't say, oh, I can do it and you don't need that. But they brought it to me to manage my pain and appetite and all the kind of things. And we do that. I have an appointment every 2 to 3 weeks. They're very flexible. And a big part of that is I have pain. I'm tired. I can't drive right now because of the pain meds. So they come to my house to do the appointments, which is just great because it's so easy for me to just kind of sit up on the couch and tell them, go through everything that's changed or new pain or anything like that. And they're available anytime that I need. So I know mine wasn't as in depth as what Dr. Tindall was, but this is kind of my experience over the past couple months with palliative care, and it's really helped with a lot of things and take burden off of my family even with that. And there's so many other resources that I haven't tapped into that I know are part of palliative care. So I think there's a question and answer session, and I can answer any question you may have.
Thank you, Lindsay. I'd like to invite Dr. Tindall to come back on camera with us. Thank you so much for sharing your valuable information with us, Dr. Tindall and Lindsay. I know it's really important to our audience and their care of breast cancer patients. So we're going to move on to some discussion, and we do have a question. We have about 15 minutes, so we'll try to get to as many questions as we can. And so make sure you put those in the Q&A box for us. Okay, so one question that I wanted to get to right off the bat is you were talking about faith and palliative care. So there was a question that came in. Are there faith-based palliative care practices to address the spiritual needs of patients?
Yeah, that's a great question. So we care for patients from a wide variety of spiritual backgrounds. And so we maintain a neutral sort of perspective from a faith perspective, but we want to make sure people get access to what they need. So generally speaking, we work with chaplains who can attend to people's spiritual needs no matter what their faith background. But sometimes people really want to connect with their specific faith religious leaders or communities. And in that sense, what we'll do is try to make that connection to make sure that they have what they need.
Great, thank you. There is a comment in the chat box directed towards you, Lindsay. It says, thank you for sharing your story as a patient navigator. It's so helpful to know how I can better serve patients who are curious about this type of care.
Great.
So I'm going to move on to another question. Because palliative care is often associated with hospice, what are effective strategies to offer palliative care to cancer patients?
Yeah, that's something that our field has struggled in on one side, it's sad and it's challenging because hospice in itself is such an amazing support for patients and families when that is the right thing. And so, we want to recognize that we're not hospice. We respect and appreciate hospice. We work with some colleagues that are just amazing at what they do. But when we speak about palliative care, we really talk about the fact that we're there to attend to patients to help them live fully. And we use terms like a serious illness and focusing on quality of life. We definitely will be with patients and families from the entire spectrum of their life. But hospice is really narrow in the sense that when we're talking about hospice, we're usually really focused on people staying at home, receiving comfort-based care, and we're approaching end of life. And palliative care is not that. We're really in a place where people can be living quite fully, and our goal is to help them to live as well as possible. And so when we're talking to patients and families, we really don't want to close the door on any sense that what we're talking about is just hospice. And so we try to sort of focus on the fact that what we do is really different. So we say palliative care is caring for people with serious illness to help them have the best quality of life, to reduce the stresses of the illness that they're living with. And a lot of times I find that when people come to us, even with the best introduction possible, sometimes their anxieties are still a little high and they're not really sure what to expect. But usually within a couple visits, they recognize that all we're there to do is help support them. There's nothing, we're probably the least frightening humans that have ever walked to the planet. And we're really there to meet people where they are, where we want to offer our support and our advice, and we want to have the important conversations so that they are empowered to make good decisions for themselves. But we're going to do it in a way, once we know patients, in a way that's going to be well received and in a way that's best for that individual person. So, we use terms like patient and family centered, and we really do try to approach the care in that way. So when you're talking to patients and families, I think it's really important to use the phrases of it's specialized care for the seriously ill, and to let them know what our focus is on helping them to live well.
Great. Those are some great terminology to use. Thank you. Lindsay, there's a question that came in for you. If there are, how are spiritual care needs addressed in your particular journey?
If there are
spiritual needs for you.
I just had this conversation with my old boss a couple days ago, and trying to really focus. Sometimes I think it's a habit to go to church, especially when you're down, and that's when your side effects start kicking in a couple of days after treatment. And I try to read, I pray to myself, and that's what I was talking about with my old boss, is just trying to find a relationship with Jesus instead of feeling like I have to go to church and I have to do all these things that are more religious than spiritual per se. So I mean, I don't have much else to say about it. I hope that answered.
So it's more of an inner journey that you're
Yes.
Working on, or then reaching out to chaplain and other
Correct.
Religious entities.
Correct. And I've talked to a couple pastors and preachers. I'm baptized Catholic, but I'm open to all different kind of like thoughts in areas in spirituality and everything else. So I've talked to different pastors, and I'll usually get something from each of them, but I haven't found a church that I've really liked down here or anything like that. It's more just kind of reading to myself, kind of meditating to myself, and taking and appreciating prayer.
How was your experience with palliative care and the spiritual aspect? How did they offer that to you, and how had they been supportive in that area?
I mean, they've gone over different aspects. I don't know if they've even asked me about spirituality, because I've been so set on a couple other things that have made me debilitated. So it's not really something that's come up, and I'm at a place where that's not like a significant need I need from them.
Mm-hmm. Okay.
So
okay, great. I know we were talking about the strategies to talk to cancer patients. So this is about families. So how to involve family members, main caregivers to accept and embrace palliative care. So I'd like to hear from both of you. Lindsay, do you want to start?
Sure. Let me pull up the question because I am a visual person. Is it?
It's one of the questions that I'm asking. So it's not in the chat box. But how to involve your family. So how were you able to involve your family members, your caregivers, to embrace this palliative care?
So I think there's 3 main people kind of in my family, and it's my sister, my husband, and my mom that I feel like are my main caregivers. I have few other people that are kind of like main, but not, they're like a little bit below that level. So my husband, he works nights, so he's asleep during the day. And I think he's been up and kind of like crossed by and hi, and we talk about it after. My mom is a physician, so she knew more about palliative care than I did, and was already on board, and has definitely been like, this is the time to call your palliative care team. And that's kind of the same with my sister. So I don't think it was very difficult for them to get on board, especially with how much pain I was having and different chemo regimens and just a lot of things changing. They appreciated the extra source to help deal with my side effects and see what medicines I already have first, what I possibly need to get. It wasn't just like, you need this, this, and this, and this, and you have to get all those and throw all your other medicines away. They're very much like, okay, what are you doing so far? Let's change this little piece here or add this much here. So it wasn't overwhelming for me either. I think that was the other part. I've done some like naturopathic or other like alternative medicine kind of things, and it's kind of like they're just throwing everything on you saying you need to take this. And so far palliative care hasn't been like that at all. It's just kind of like, well, let's try this and see if this helps.
Great. Okay, I'm glad you have a supportive family. That's amazing.
It's been
Dr. Tindall, would you like to address the question?
Yeah, sure. I think similar to how we talked about bringing it up with the patient, the real focus is just on the ways that we can help support them, and the fact that we're there to help support the caregivers and the families too. We're always looking for, if it's not us, our team that has the tools, what kind of ways we can connect people. Lindsay's had this experience, but for kids, we are able to connect with a nonprofit in town called Wonders and Worries. I actually sit on their board, and they provide support specifically to kids whose parents are dealing with a serious illness. And so what we hope to do is kind of create this network of people. I mean, similar with the organization here, we want to make sure people have the full sort of everybody around them that can help them is involved. And so for patients and for families and caregivers, I think it's almost easier to say, there's really no downside. They're going to get some extra support. They're going to feel better empowered, better able to take care of their loved one. And they're going to have people that are checking in on them also. The other thing is, when we're in the hospital setting, provide palliative care, it's important to be there because there's a lot usually happening. But a lot of times you're only getting to meet with the patient. And when you get to go into the home, sometimes you get the experience of getting to meet everybody, and that allows you to really know them and involve them. And that's been a really, really wonderful experience from my standpoint. And I think being able to make sure that we're addressing their needs too in that same visit has been impactful to families also.
I think so.
Right. So we have a couple questions. Someone's asking if you could address how palliative care teams can help with financial matters.
Yeah. So, there's a couple of different ways we can do that. Our social workers often really focus on what resources exist. So like I saw a family the other day that the son has quit his job and is a full-time caregiver for his dad. And obviously that's very financially straining because his dad can't work either. And so there are ways that you can actually get reimbursed to be the caregiver, but it's a really complicated process. And to be honest, I don't even know the whole thing, but she is expert at that. And so after they let me know that, I was able to connect her with the son, and they were able to start the process. Another thing that we do is talk about, what insurance covers and doesn't cover, ways to make sure that we take full advantage of sort of state and local resources that people might not be aware of, where we can reduce the financial burden. On our team, we actually work with Austin American Statesman to run a campaign where we receive donations to create what we call a special needs fund. And we're able to actually help people who, they have to sort of have the need that meets our criteria. But after that, we can help them with groceries. We can help them with medications they can't afford. We can help them with transportation. And we try to just sort of fill in some of those gaps. It's hard for people to focus on their health if they're not sure where they're gonna, that they're gonna have a roof over their head or groceries in their fridge. And so we try to take those things off their plate as much as we can.
Right. Thank you. There's a comment in the chat. I'm a CMO in Ohio, and I've been on a soapbox trying to get our company to reimburse palliative to the level that needs to be done to encourage more of it and start the education piece early.
And I guess they're asking for advice on how to accomplish that. Well, thank you for being such an advocate for palliative care, first of all. It's really tough. I spend, in my role as a medical director, I spend part of my time, which I love, being with patients and families, but another whole part of it is making sure that this program can function and keep its doors open. And we're in a place where reimbursement really doesn't match what we want to provide from a palliative care perspective. We have a grant to be able to help support that, while we're also working on getting in front of insurers to advocate that we can really do a lot that can have a huge impact on patients and families and quality. And we can also do things that benefit the insurers, and same thing with hospital systems. So, we're not big money makers like surgeons are in a hospital setting. And so it's easy to kind of not recognize the impact that a palliative care team can have. But when you look at the potential for money savings, and you can look at the potential for impacting quality of care, reducing readmissions, keeping people who don't want ICU care out of the ICU, decreasing the length of stay by helping to make sure that we're providing the support on the outpatient side, those kind of things can be really, really add up. And there's, if you're a member of CAPC, which is our national organization, the Center for the Advancement of Palliative Care, there are actually toolboxes and what we call impact calculators. So you can put in, what you can do to reach patients in a hospital setting, and it can help you to sort of come up with some of these arguments. I'm happy to talk offline about it because it's probably not as interesting to everyone else, but it's very difficult and not everybody kind of gets it. And I just met with a hospital system that wants us to come in and do inpatient work, and but they don't want to provide any support. So, I explained, I gave my best pitch, and they said, we don't put soft money after hard, we don't put hard money after soft money. And I thought, this is not a great collaboration. We really want to be in places that we can really achieve things with people that understand the work we do.
So still growing and still working and getting acceptance out there. We are almost out of time, so I would like to give you a chance if you have any final thoughts. Lindsay, any final thoughts, anything you'd like to share here at the end?
Not right now. There hasn't been any negative things I've had to say about palliative care that I received this past 2 months. I mean, there isn't anything bad about it, really. It's all beneficial, and it has been beneficial to me and my family.
Great. Thank you so much. Dr. Tindall, any final thoughts?
I don't think so. I think I've shared everybody. It's, this work is at times very difficult, but there are people out there like Lindsay that, even if we can do a small amount to make things a little bit easier with all the things that they're going through, then that's what we want to do. So it's rare that we can't find a way to help in some way. Like Lindsay said, there's no negative if it's done well. And so I would just encourage people to be advocates for it, and hopefully we can make sure that we take care of as many patients as possible that might benefit.
Yeah.
Great. Thank you, Dr. Tindall and Lindsay, for sharing your expertise and valuable insights with us today.